This is a presentation about pain neuroscience education. This is meant to educate occupational therapists and hand therapy specialists about pain neurophysiology, pain neuroscience education, and how best to implement pain neuroscience education into client intervention sessions. There are 6 objectives therapists should be able to meet by the end of this presentation. First, therapists should be able to understand and articulate the gate control theory of pain. Second, therapists should be able to describe the purpose and actions of the central and peripheral nervous systems. Third, therapists should understand and articulate the processes in the fear avoidance model. Fourth, therapists should be able to describe the purpose and goals of pain neuroscience education, also referred to as PNE. Fifth, therapists should be able to employ various teaching methods to educate clients about PNE. Sixth, therapists should be able to select and apply appropriate interventions to use alongside PNE in client intervention sessions. To begin, let's discuss the gate control theory of pain. This theory of pain is the most widely accepted model of pain in current practice. This theory posits that there is a gate allowing or prohibiting pain signals to reach the brain. There are 2 main types of fibers involved: C fibers and alpha-beta fibers. C fibers transmit signals slowly and are activated by pain and changes in temperature. A beta fibers transmit signals quickly and are activated by non-noxious stimuli, such as pressure or light touch. If interneurons, also referred to as inhibitory neurons, are stimulated by A beta fibers, they block the projection neurons from sending signals to the brain. This effectively closes the gate and prevents pain signals from reaching the brain. As the A beta fibers transmit signals quicker than C fibers, they can ultimately block the pain signals from reaching the brain by stimulating the inhibitory neurons, which prevents the projection neurons from sending signals received by the slow transmitting C fibers. Now, how do these neurons send signals to each other? This process occurs through action potentials in our cells. Action potentials can only occur in our neurons and muscle cells. At rest, our cells stay around an electrical threshold of about -70 millivolts. An action potential only occurs when a stimulus acts on the cell's electrical threshold, causing it to decrease. Once the cell reaches a threshold of about -55 millivolts, it quickly depolarizes. This depolarization continues until it reaches the cell's electrochemical equilibrium, or peak, at around +30 millivolts. The cell then quickly repolarizes and attempts to return to its resting potential. The cell overshoots the resting potential and becomes hyperpolarized. This is called the refractory period, during which the cell cannot attempt another action potential. Gradually, the cell returns to its resting electrical threshold of -70 millivolts and is ready to send another action potential. In neurons, these action potentials originate from the cell body and travel down the axon of the neuron to the terminals. These terminals are where the neuron's synapses are located, which allow it to send the signal to other neurons. Through this process, signals are passed along neuron to neuron until they reach the brain. Your brain processes information from these signals passed along neurons through the central and peripheral nervous systems. The central nervous system, or CNS, is composed of the brain and the spinal cord. It collects and processes information received from the nerves and decides how to proceed. It then sends out signals telling the nerves how to respond appropriately to stimuli. The central nervous system regulates everything the body does. The peripheral nervous system, or PNS, is divided into two subsystems, the automatic and somatic nervous systems. The automatic nervous system controls actions your body does automatically, such as breathing or blinking. The somatic nervous system controls voluntary actions, such as movement. These two subsystems receive information from the environment around you and send it to the central nervous system. The responses sent from the central nervous system are completed by the peripheral nervous system, which allows you to interact with the world around you. After an injury, either the central or peripheral nervous systems can become sensitive to stimuli. When the central nervous system is sensitive, it processes the information received from the peripheral nervous system as increased or hypersensitive. It then tells the peripheral nervous system to respond appropriately to the increased stimuli. This results in an amplified sensory input across the entire body. This is called central sensitization. Peripheral sensitization is the same concept. The peripheral nervous system processes the environmental stimuli as increased and sends that increased response to the central nervous system. The central nervous system does not know that anything is incorrect, so it tells the peripheral nervous system to respond appropriately to the increased stimuli. This results in hypersensitivity to environmental stimuli. Either central or peripheral sensitization can result in changes in pain perception. This can be increased sensitivity to pain, called hyperalgesia, pain from non-painful stimuli, called allodynia, or experiencing pain without the presence of stimuli, called nociceptive pain. When you experience pain, several areas of the brain are involved. These areas can communicate, interact, and develop a map of pain in the brain. This map is called a pain neuromatrix. As areas of the brain experience pain, they tend to neglect their proper function. When pain remains and becomes chronic, these areas can remain focused on dealing with and experiencing that pain. This can cause difficulties in daily life as those brain areas are no longer properly completing their intended function. This can result in impairments such as poor memory, loss of focus, difficulty maintaining the body's temperature, or difficulty sleeping, among others. How can we use what we have learned so far to address client pain experiences and perceptions of pain? To address pain experiences and pain perceptions, we can use the fear avoidance model. This model considers the psychological aspects involved in perceiving and experiencing pain. We know that after an injury, pain is experienced. After pain is experienced, there are two options: to be afraid of pain or to not be afraid of pain. Let's focus on the fear of pain. When fear of pain is present, oftentimes clients can avoid activities they think may increase or otherwise aggravate that pain. Activity avoidance can lead to disuse of the injured extremity, disability, and depression from decreased engagement in valued activities. This can lead to further pain as clients attempt to engage in activities, resulting again in fear of pain, thus continuing the cycle. When there is no fear of pain after an injury, clients can begin to confront their perceptions about pain and acknowledge that while pain is meant to act as a protective factor, it can be overprotective and impair daily functioning. With that confrontation and acknowledgement, clients can begin to recover fully from their injury. Ultimately, therapists must try to dissuade pain catastrophizing and fear of pain in clients in order to prevent the cycle from continuing and promote client recovery. To do this, therapists can use pain neuroscience education. PNE is a developing model of pain education that aims to educate clients about the biological and physiological processes involved in processing and experiencing pain. PNE acknowledges that the pain a person is experiencing is real and can be adapted. There are 3 goals of PNE. First, PNE aims to decrease focus on issues associated with the anatomical structures experiencing pain. Second, PNE aims to address client perceptions of pain. Third, PNE aims to reconceptualize the client's pain. While PNE is a developing model of pain education, existing research supports its use. PNE has been used with a variety of populations, ranging from chronic low back and neck pain, rotator cuff tears, fibromyalgia, and chronic fatigue syndrome. PNE has been shown to reduce pain, improve psychological factors such as anxiety, fear, and depression, and improve pain knowledge in populations experiencing chronic musculoskeletal pain. PNE has been shown to be most effective when combined with physical treatments, resulting in significantly improved pain. No current literature has shown PNE to be effective in reducing pain when used as a standalone treatment. PNE has been shown to be effective in addressing and changing pain knowledge, attitudes, and beliefs held by therapists. This change was maintained 1 year later at follow-up. Regarding client knowledge about pain, it has been shown that providing even 30 minutes of PNE significantly improves a client's pain knowledge, improving the potential to improve pain. As PNE is still developing and evidence is being published, not much is known about the efficacy of PNE in the Veterans Health Administration, or VHA. However, current evidence shows promising results when used with veterans experiencing chronic, non-cancer pain. As you learn more about PNE, you may ask yourself what types of clients are best suited for PNE provision. PNE is appropriate for any client experiencing functional impairments as a result of pain. But those who benefit most from PNE include those with high levels of fear and pain avoidance, increased pain catastrophizing, and the presence of central sensitization. It is also important that clients are open to changing their behavior, as without change, pain will not improve. Typically, clients who have received PNE are in their 40s and are female. With this information, it may put VHA therapists off of PNE provision, perceiving it as ineffective due to the demographics of the VHA client population. Most veterans who utilize VHA services are in their 60s and male. However, veterans are more likely to experience chronic and intense pain as a result of their service, which would make them a primary population to receive PNE. When providing education to clients, it has been shown that using an active teaching-learning strategy promotes client engagement in the education. PNE has been provided in multiple formats, such as slideshows, videos, drawings or diagrams, brochures, metaphors, and scenarios. PNE is best provided in a story format to increase client engagement and retention. Typically, PNE is provided in 4 or 5 hour-long treatment sessions, but can be broken up and spread out among further sessions. As this education is not effective when provided on its own, it is typically combined with physical interventions to promote the most benefit for clients. When providing PNE to clients, they should be provided homework or a summary of covered topics. This is meant to allow the client to reflect on the learning experience and develop questions for the therapist as needed. PNE content can cover many topics related to pain, pain perceptions, and pain experiences. PNE most often covers the neurophysiology of pain, synapses and action potentials, central and peripheral sensitization, nervous system plasticity through the pain neuromatrix, and how psychosocial factors such as fear affect the pain experience. There is no focus on anatomical structures experiencing pain. Rather, therapists providing PNE should focus on the neurophysiology of pain and how to reconceptualize it. This guide is meant to be used by therapists to educate themselves about PNE, as well as provide client education materials for therapists to use when providing PNE to clients. The client education materials include a PowerPoint and various handouts. The PowerPoint provides education on pain topics and PNE through visuals and story-based formats. The visuals and stories use military scenarios to engage with and relate to veterans to promote engagement. The handouts provide overviews of pain topics and concepts and PNE covered in the client education PowerPoint. The handouts are meant to be provided to clients in order for the clients to review the associated material at home and promote further questions about pain. The PowerPoint and handouts are intended to be provided together to promote client understanding and knowledge of PNE, both in the clinic and at home. To help clients reconceptualize their pain, therapists can take the client through the fear avoidance model and discuss how avoidance and catastrophizing may increase pain. Therapists can also reassure the client using common phrases, such as sore but safe, motion is lotion, you may take the pain to dinner, but don't date it, and hurt does not mean harm. Therapists who provide PNE want to reduce client fears about pain and have clients realize that pain and their experience of it can be changed. This is done most effectively in conjunction with physical interventions, as that can empower clients to engage in valued occupations while in a safe, therapeutic environment. This is a non-exhaustive list of intervention options that can be provided alongside PNE. Therapists are welcome to pick and choose what best suits their practice, client preferences, and client contexts. To conclude and summarize the main points of this therapist education, PNE is most appropriate for use with multiple client populations experiencing pain. P&E is best implemented and most effective when provided alongside physical interventions. Clients who are best suited for P&E are those with increased fear and avoidance of pain, increased pain catastrophizing, and central sensitization. The goals of P&E are to decrease focus on anatomical structures experiencing pain, address pain perceptions, and reconceptualize the pain experience. Thank you for taking the time to learn about P&E and its implementation in therapeutic practice. If you are interested in learning more, here's a list of references used to develop this therapist education.